Hello, everyone. Welcome to Doc Talks. So we have the CRC updates from GI24 series of Doc Talks today. The first part is on rectal cancer. So first we have Dr. Christian Jethwa from Mayo Clinic talk to us about radiation therapy in rectal cancer and updates. Okay.
Thanks a lot for the kind introduction, Manju, and the invitation to join. It's a real honor to be chatting with you all, and it's even more fun to hear the patient perspective as it helps guide the clinical decisions to emphasize important endpoints and important outcomes from the patient perspective. So I can very confidently say that this is a nice bi-directional learning opportunity, both for myself and I hope for you all as well. So I'm planning to discuss evolving treatment paradigms in rectal cancer, specifically from the radiation therapy perspective. So the themes of the discussion today will include discussing MRI-defined risk factors of recurrence for rectal cancer, including both local, regional, and distant recurrence risk factors, radiation therapy regimens, including short course versus long course chemoradiation, and a personalized local therapy approach, including selective omission of radiation therapy or selective omission of surgery. We know that the German and Dutch TME trials have demonstrated that preoperative radiotherapy, utilizing either long-course chemoradiation or short-course radiation therapy, improves pelvic control for patients with rectal cancer. But as you all know, both radiation therapy and surgery are associated with acute and late toxicities, including long-term bladder, bowel, sexual, or endocrine dysfunction. So the obvious question is, how can we better tailor local therapies to balance quality of life and oncologic outcomes for our patients? So first, I'd like to review which patients may safely omit radiation therapy. Locally advanced rectal cancer is a highly heterogeneous disease with a broad spectrum of risk of both distant and pelvic recurrence. Understanding these risk factors is really critical in clinical decision-making. Patients with T1 to 3B disease and no additional risk factors in general have a relatively favorable risk profile. However, strong risk factors for distant recurrence include elevated CEA, extramural venous invasion, tumor deposits, T4 or N2 disease. Patients with these risk factors may derive benefit from an intensified systemic therapy approach. Strong risk factors for pelvic recurrence include clinical T4B disease, compromised mesorectal fascia, involved lateral pelvic lymph nodes, distal tumors within 5 centimeters from the anal verge, or extramural venous invasion. In particular, it's extramural venous invasion when associated with a low rectal tumor that is associated with a strong risk factor of pelvic recurrence. Patients with these risk factors may derive benefit from an intensified local treatment approach, such as radiation therapy. But first, let's talk about this relatively favorable risk group with T1 to 3B disease and no additional risk factors. The Mercury, Occam, and Quicksilver studies have each utilized the preoperative MRI to identify a relatively favorable risk cohort of patients. Patients predominantly had mid to upper rectal tumors, clinical T2 to 3B, node negative, with clear mesorectal fascia, and no evidence of extramural venous invasion. Patients were treated with upfront surgery with omission of radiotherapy, and chemotherapy was generally reserved for those with pathologic lymph node positive disease. This approach was associated with a less than 5% risk of involved circumferential resection margins, and at 5 years, a less than 5% risk of pelvic recurrence. The Prospect study is another very important study in this space. The study was much more heterogeneous, including patients with clinical T2N1 or T3N0 to 1 disease. Importantly, patients were ineligible if they were not amenable to low anterior resection or had T4 or N2 disease, or any disease, primary tumor or lymph node, within 3 millimeters of the CRM. Patients were treated with either standard long-course chemoradiation or with an experimental regimen of 6 cycles of induction FOLFOX, and if there was greater than or equal to 20% primary tumor response, proceeding with TME surgery with omission of radiation therapy. The study met its primary endpoint, demonstrating that the selective omission of radiotherapy approach was associated with non-inferior disease-free survival with 80.8% versus 78.6%. Very notably is that the pelvic control was exceptional on the study. It was approximately 98% in each of the 2 cohorts. If we look at adverse effects, preoperative FOLFOX arm was associated with a higher rate of grade 3 to 4 acute toxicities, with 41% compared with 23% with the chemoradiation arm. The investigators very nicely included patient-reported outcomes on this study, and they demonstrated that, as you may anticipate, preoperative chemoradiation was associated with a higher rate of acute severe diarrhea, whereas the preoperative FOLFOX arm was associated with significantly higher rates of severe toxicity in other domains, spanning mood concerns with anxiety or depression, GI concerns such as appetite loss or nausea, fatigue, and, as you may anticipate, neuropathy. They also demonstrated that there was no significant difference in quality of life between the two treatment cohorts at any time point, including acute treatment phase or in long-term follow-up. Chemoradiation was associated with poor bladder function and bowel function in the acute treatment phase 1 to 2 weeks before surgery, but in long-term follow-up, there was no significant differences in either bladder or bowel function. Importantly, there was a significant difference in long-term sexual function in both men and women, with preoperative chemoradiation having poorer outcomes. So based upon these data, I think we can very confidently say that radiotherapy may be safely omitted in patients with favorable risk locally advanced rectal cancer, including those with tumors in the mid to upper rectum, clinical T2 to 3, with a clear mesorectal fascia, and 0 to 1 disease, as long as lymphadenopathy is limited to the mesorectum, and in those who are planned to undergo a low anterior resection. This approach is very appealing in young premenopausal women with the goal of preserving fertility or ovarian endocrine function. So next, I'd like to segue into high-risk rectal cancer, meeting these criteria here and here. These patients may derive benefit from an intensified therapy approach. So both the RAPIDO and PRODUCE-23 studies suggested that total neoadjuvant therapy, inclusive of both neoadjuvant chemotherapy and radiation therapy, may improve disease-free survival and potentially even overall survival when compared with long-course chemoradiation alone for patients with high-risk rectal cancer. In addition to these studies, the PROSPECT, CONVERT, and FORWARK studies have each informed us that there's likely a subset of patients with locally advanced rectal cancer who are effectively treated with preoperative FOLFOX and selective omission of radiation therapy. However, it is notable that these studies were not particularly representative of patients with high-risk features. For example, PROSPECT and CONVERT each excluded patients with compromised mesorectal fascia. And additionally, each of these studies had relatively limited representation of patients with T4, N2, EMVI, or involved lateral pelvic lymph nodes. Therefore, despite the favorable outcomes shown in each of these studies, I do think that some caution is still warranted in the generalizability of the data. And at least at present, I would suggest that total neoadjuvant therapy, inclusive of radiation treatment, is likely the best approach for patients with high-risk disease, such as clinical T4, compromised mesorectal fascia, N2, lateral pelvic lymph nodes, or extramural venous invasion. So let's summarize. So in patients that have clinical T3A to B and 0 tumors limited to the mid to upper rectum, I think we can be pretty confident with omission of radiation therapy. Options could include upfront surgery with selective use of postoperative therapies, a preoperative chemotherapy approach followed by surgery per PROSPECT, or of course, preoperative radiotherapy is still a reasonable option in this cohort. On the other end of the spectrum, patients with high-risk disease, such as clinical T4, compromised mesorectal fascia, N2, lateral pelvic lymph nodes, or EMVI, these patients are best treated with total neoadjuvant therapy, inclusive of radiation treatment, of which there are many suitable sequences and radiotherapy approaches. And then, of course, there's the intermediate risk group, which is probably the most nuanced and complex. I would suggest that these patients would include patients with bulky T3C to D and 0 primaries, node-positive disease, or distal tumors. For patients that have isolated N1 disease limited to the mesorectum and no additional pelvic risk factors, I think we can be pretty confident in a PROSPECT-type approach, treating with chemotherapy, followed by surgery and selective omission of radiation treatment. However, patients who have additional pelvic risk factors like bulky T3C to D primaries, tumor deposits, EMVI, or a distal tumor, I think the addition of radiation therapy may likely be the most appropriate approach in these patients. Next, I'd like to talk about short course versus long course radiotherapy. Multiple studies have looked at this question of preoperative long course versus short course, and perhaps the most notable two are the Polish one and TROG studies. Each of these studies included a relatively average risk cohort of patients, and they identified similar rates of pelvic control, disease-free survival, and overall survival with each treatment regimen. We did note that long course chemoradiation was associated with improved pathologic complete response in each of the studies, but it's notable that each of the studies sequenced therapy with short course followed by surgery within 1 week, which is not really sufficient time for response. The Stockholm 3 study taught us that by adding a 4 to 8 week delay after short course radiation therapy, that it could also augment treatment response. However, the RAPIDO update, for which the study was enriched with patients with high-risk rectal cancer, suggested that despite improved disease-related treatment failure with TNT, inclusive of the short course radiotherapy backbone, there was also a higher risk of pelvic recurrence with rates of approximately 10% versus 6%. These data at least provide some suggestion that long course chemoradiation may be the preferred approach for patients with high-risk rectal cancer and local regional recurrence risk factors. So at least in my practice, I use long course chemoradiation for patients with clinical T4B primaries, extreme mesorectal or lateral pelvic lymphadenopathy, compromised mesorectal fascia, or distal tumors within 5 centimeters of the anal verge. And I also use long course chemoradiation for patients being treated with non-operative intent, at least for now. The German study will provide a lot more clarification of this short course versus long course question. Next, I'd like to segue into organ preservation. So this is a real key point that I'd like to emphasize. The goal with organ preservation is to preserve patient quality of life and function. Sparing the organ and sphincter is simply the surrogate to achieve those means. We know that patients that have a mid to low tumor in whom a low anterior section may be feasible, but would result in a low or coloanal anastomosis, generally have poor bowel function after surgery. We also know that the combination of radiotherapy and surgery is associated with significantly poor bowel, bladder, sexual, and pelvic floor health after treatment. Therefore, selective omission of surgery or selective omission of radiation therapy may offer a more favorable quality of life profile in some patients. So the OPRA study is really critical in this space. This study included 324 patients with stage 2 to 3 rectal cancer. Patients were compared, at least treatment sequences were compared. All patients got chemoradiation followed by either FOLFOX or preceded by FOLFOX. And those that had a complete or near complete response were eligible for active surveillance. OPRA demonstrated that a chemoradiotherapy first approach was associated with improved 5-year organ preservation with rates of 54% versus 39%. And there were no differences in disease-free survival or overall survival between the treatment arms, suggesting that chemoradiotherapy first approach is preferable. So at least from the radiation therapy perspective, you may ask, how can we improve upon these outcomes? There are recent data that suggests that radiotherapy dose intensification is associated with favorable outcomes amongst select patients. For example, the OPRA and Morpheus studies have suggested that brachytherapy boost may be associated with exceptional clinical complete response rates approaching 90%. And the Danish WW2 study used a regimen of 62 gray and 28 fractions and also suggested exceptional clinical complete response rates. So I'd like to highlight the OPRA study a little bit further. This study included a relatively favorable cohort of patients treated with external beam chemoradiation to either 54 gray or 45 gray combined with a brachytherapy boost. And those who had a complete response proceeded with active surveillance. The study demonstrated that at 3 years, 81% versus 59% had organ preservation with better outcomes in the brachytherapy cohort. And there was no significant difference in severe toxicity and long-term functional outcomes between the two treatments. These data support the value of radiotherapy dose intensification for organ-preserving treatment approaches. So to conclude, effective treatment of rectal cancer requires multidisciplinary collaboration. Guidance of neoadjuvant therapy is dependent upon accurate risk stratification. There's increasing consideration for a single local treatment modality for select patients, and that local modality should be determined by impact on function and quality of life. That's a real key. Radiotherapy may be omitted for select patients with MRI-defined favorable risk, mid to upper rectal cancer, who are LAR candidates and not interested in organ preservation. That could include patients with T1 to 3B N0 tumors with a clear MRF and no additional risk factors. Options could include upfront surgery or neoadjuvant chemotherapy followed by surgery. And then select N1 patients with lymphadenopathy limited to the mesorectum or superior rectals with no additional risk factors. This is a really great patient cohort to consider a prospect type regimen. Total neoadjuvant therapy is preferred for patients with high-risk rectal cancer. Long-course chemoradiation is preferred for patients with high risk of pelvic recurrence or those preferring organ preservation. Chemoradiation followed by chemotherapy is the preferred treatment sequence for organ preservation. Radiotherapy dose intensification improves clinical complete response and organ preservation. And there are significant ongoing investigations into these important questions, including systemic therapy intensification like Janus and radiation therapy dose intensification. Thank you very much.
I am going to talk about colorectal cancer screening, which it seems like a timely topic given March being Colorectal Cancer Awareness Month. So I was really excited that at GI-ASCO, we were able to have a session on colorectal cancer screening, and we really had like the world experts there to debate the issues and talk about the issues. So our panelists were Dr. Bretthauer from Norway. He was the PI of the Nordic trial. TR11 from Kaiser, who's done a lot of work in stool-based screening. Asma Shaukat from New York, who is really a leader in blood-based testing. And I was able to moderate this with Bryson Katona at UPenn, who's also a gastroenterologist. Okay, so I just went ahead and kind of summarized some of the, or put together some of the major slides with the important points from the debate. So just starting with some background. So as I think we all know, these are US guidelines for colorectal cancer screening that have recently been lowered from age of initiation from 50 now to 45 years, which has a grade B recommendation. And there are many options for colorectal cancer screening, ranging from colonoscopy, which is the most frequently used, to less commonly used methods like a CT colonography. But I think people were sort of surprised to see that actually the US is an outlier in recommending colonoscopy as the gold standard. If we look at different countries across the world, actually FIT is the most commonly recommended screening method. Really only the US and Abu Dhabi, probably, you know, the sultans and the queens there, are also getting colonoscopies, but really across the world, FIT is the #1 screening method recommended. So the first part of our session is we had a debate between Dr. Bretthauer, who argued that scopes should be the recommended screening modality, and Dr. Levin, who argued that stool-based testing with FIT or FOBT should be the primary screening mechanism. And I'll kind of go ahead and summarize their points and also talk a little bit about the Nordic trial. So basically what Dr. Bretthauer argued is that a colonoscopy or a sigmoidoscopy is both diagnostic and potentially preventative or therapeutic. So they reduce the risk of getting cancer in addition to seeing a cancer. And also they last for a long time. So you do one and you may be good for 10 years. You don't have to go back every year. That can give you peace of mind. I want to talk a little bit about the Nordic trial, which I'm sure you've all heard of it. It was published, I think, in 2022, and made a lot of press. But basically, this was a randomized trial done in 4 countries, Norway, Poland, Sweden, and the Netherlands. And it randomized a healthy population to invitation to a one-time colonoscopy versus no screening at all. And the primary endpoints were colorectal cancer incidence and mortality after 10 and 15 years, and the 10-year outcomes have been reported. So these were the participants. It was an amazingly large trial of almost 90,000 participants from 3 countries. You can see the screening participation is different by country. The highest in Norway, 60%, was similar to what we have in the US, and then lowest in Poland and Sweden. And this gets into a little bit how we might interpret the findings. You can see their adverse event rate was very, very low, and that actually has to do with the fact that they do screening with no sedation. So if the patient is not sedated, then they'll tell you if they're hurting, and then you might be a little bit more gentle. Another really important part of this trial is that there was almost no contamination. So what does that mean? Contamination means that if you're randomized to the non-intervention arm, so that no screening arm, you actually get the screening test, and that can really dilute the results. So because in these countries, the baseline was not to screen, patients in the control arm did not get any screening. So we think these results can be more reliable for that reason. So what did the study find? So again, the 10-year outcomes have been reported. We're eagerly awaiting the 15-year outcomes, but by intention to treat, which is on the left. So what does intention to treat mean? These are all the patients who are randomized to that strategy, whether or not they actually got the colonoscopy. So we can see that randomizing to a colonoscopy strategy reduced the risk of colorectal cancer incidence, but had no change in risk of dying from colorectal cancer and also no change in mortality. If we look at the per protocol analysis, what does that mean? This means actually looking at the patients who went and got the test. You can see that there was a small reduction in the risk of in colorectal cancer and a smaller reduction in the risk of death from colorectal cancer, but no difference in overall survival. So there was a lot of debate after this large study came out. Obviously, you know, is this a positive study? Is this a negative study? How do we interpret it? How do we extrapolate it to the U.S.? You know, I think there are many nuances to the study, and I think Dr. Brett Howard sort of did a good job summarizing them. But I think the take home is that an invitation to screen, where about 42% of patients got the colonoscopy, did not reduce the risk of did not improve survival or reduce the risk of dying from colorectal cancer, but decreased the risk of getting colorectal cancer. However, one can surmise that if more patients actually got the test, then the results might be different. But obviously a lot of nuances, and we may get an update at 15 years. Another question is, well, between colonoscopy and sigmoidoscopy, what is the best test, right? A colonoscopy visualizes the whole colon and rectum. A sigmoidoscopy visualizes the distal third. The sigmoidoscopy is less prep. A colonoscopy requires a day off work, requires sedation, etc. There's actually a meta-analysis of 4 randomized trials looking at sigmoidoscopy that actually do show a reduction in death, which is not the case for colonoscopy. But what Dr. Brett Howard argued is that he likes colonoscopies more. He feels that it's easier to visualize because of the prep. It's really a one-time thing done once, and then you're good for 10 years. And then really specific to Norway, it's actually done without sedation. So it's actually a less involved procedure. So he prefers a colonoscopy. These are slides from Dr. Levin, who argued on the side of stool-based tests versus FIT or FOBT. So what is FIT? What is FOBT? We use them interchangeably because they're both stool-based, but they're different. And FOBT is looking at any blood. It's a guaiac test versus FIT looks at, uses an antibody specific to human blood. So it's more accurate. So really FIT has replaced FOBT. But because a lot of the older studies use FOBT, we still use that term. And sometimes you'll see that, you know, here it says FIT versus FOBT. So Dr. Levin's main points were that a screening test is not going to help you if you don't get it, right? You have to get the test. And his point was that study after study shows that when patients have the option, they're going to choose FOBT or FIT over colonoscopy. So the adherence is almost always higher. And we can see these in these 3 studies. He led an incredibly successful outreach program through the Kaiser Health Network in California. This is sort of their schema for doing it. And it was based on FIT strategy, what they call FIT first. So everyone's invited to a FIT. If it's positive, you have to follow up with a scope-based strategy, but it's really FIT first. And he showed that if you do organized screening, that you improve screening rates. And importantly, this also resulted in decreased risk of colorectal cancer and death from colorectal cancer. This was published as a letter to the editor in New England Journal. And also importantly, you can see that the effect was in both white patients and in Black patients. So it actually reduced colorectal cancer disparities, which we know are also a big issue. So his conclusions take away really that are that really non-invasive tests, FIT, FOBT, should be the first line, but of course not the only line. They need to be followed up with a colonoscopy if they're positive. And really emphasize that really need to follow those up with a scope-based test. It's not really the only test you can get. Okay, so I try to sort of summarize this, and we can kind of go over this because I went over a lot of these points, but really Dr. Bredhauer, colonoscopy and sigmoidoscopy, diagnostic and therapeutic. You can reduce the colorectal cancer incidence, and they can detect early polyps that can eventually progress to a cancer. Longer intervals, one-time test versus annual. We have studies showing that sigmoidoscopy can reduce mortality. We talked about the Nordic trial. If you look at patients who got the colonoscopy, colorectal cancer deaths were halved, though the absolute risk reduction was a lot lower, but the relative risk reduction was half. And then he really also emphasized the importance of individualized screening based on an individual's absolute risk. Again, Dr. Levin really emphasized the importance of doing a test with higher adherence. If you have an organized screening program where you're having patients in a certain health network getting screening, then FIT makes a lot more sense. He felt due to feasibility and resources. He showed that through the Kaiser program, implementing a FIT first strategy actually decreased deaths. And I didn't present these slides here, but he also talked about multi-target stool DNA testing that could even improve the sensitivity, but right now they're still more investigational and they are a lot more expensive. So we don't have to go over this in detail, but the debate was over colonoscopy versus FIT. We will have level 1 evidence via very large randomized studies, hopefully in the next 5-10 years. These are studies done in the US, in Spain, and in Sweden, comparing colonoscopy versus FIT. You can see they have between 50,000 and 200,000 patients. So these, we think, will be definitive studies. There are slight differences in their endpoints, how they randomize patients. We have some initial results showing that, as we kind of already know, adherence to FIT is higher, but it's going to be a few more years until we get the colorectal cancer mortality and incidence outcomes. But I think we're all really looking forward to these studies to settle the debate. Summarizing those points. So the poll we made for the debate was very straightforward. Basically, before and after the debate, we asked the audience, what do you recommend as a primary colorectal cancer screening method for individuals at average risk? And unfortunately, I don't have the results here, but basically, when we started the debate, most of the audience, which was mostly US-based, voted for colonoscopy. I think it was about 2/3. But after the debate was over, it's actually quite evenly split between colonoscopy versus FIT strategy. So a much more even split between stool-based versus scope-based. So that's all I have. But welcome any questions at the end.
Yeah, thank you so much. So I wanted this a little bit about screening because usually we don't do anything about screening. And, since March was here and that there were a lot of people posting a lot about screening in their social media pages, I thought it was important for people to have like some idea about what is available for screening.
Yeah, you can see okay?
Mm-hmm.
All right, good. All right, so I'm going to cover 5 topics that I thought were important. I think all relevant to surgery because, in my opinion, patients with rectal cancer, as they go through multidisciplinary care, are all relevant to surgery. So I'll talk about 2 topics that were presented and a few abstracts that I thought were really important to talk about. So first was this abstract that was presented by Dr. Fernandez on behalf of the International Watch and Wait Consortium, which I think is important to talk about as it relates to watch and wait patients and clinical complete response as it relates to local regrowth. And I will just put this into context as you think about patients who have a distal rectal cancer and they go through treatment, and then how do you best compare these, and what do we think about local regrowth for these patients? So if you look at the watch and wait database, the local regrowth rate is about 30%, and OPRA, the rate is differing depending on whether patients have induction TNT versus consolidation TNT, and that just means whether you start with chemotherapy and treat with radiation, or if you treat with radiation and go to chemotherapy. The rate was about 29% at 5 years for the consolidation group in OPRA, and over 40% for the induction group in OPRA. But remember, these patients with local regrowth in OPRA, when they were taken to TME, there was no difference in disease-free survival for these patients. And this is the first time this was looked at in a randomized controlled trial in patients that were treated very similarly versus the data that I'm about to show you, which is not a randomized trial. So the concern is always this persistence of microscopic residual disease, as Laura suggested in her talk. And we were one of the first to identify this potential concern for patients who had local regrowth and the higher rate of distant disease in our paper on our off-protocol patients managed by watch and wait, and a higher rate of local regrowth and distant metastatic disease. In OPRA, as we updated the data, we also see that those patients who have a near complete response and have a local regrowth, there is a higher rate of distant metastasis, but is that just related to biology? And I think very likely so, because what you're seeing is patients who don't have a sustained clinical complete response, meaning we're just not good enough to identify those patients who are true clinical complete responders. And in the International Watch and Wait database, they also went back and looked at their data and showed that there was a higher rate of distant disease in those patients with local regrowth. So they wanted to, in this abstract, to look at whether or not they could do this a little more cleanly to see if the distant metastasis rate could be compared to those patients who undergo surgery. So they thought that, if you look at the incomplete responders versus complete responders, that's not a fair comparison. So they decided to look at a big group of patients in another data set. And this data set would allow them to answer this hypothesis. They felt in those that had a near pathologic response for patients who underwent surgery compared to those who had a clinical complete response and developed a local regrowth. And they looked at distant metastasis-free survival at 3 years. And so they looked at this Vikingo group and those patients who had less than 10% residual cancer cells at resection versus those who underwent local regrowth in a way that they felt like was the cleanest way to look at these patients. And interestingly, what they found is there was a difference in nodal disease, higher nodal disease in those patients who underwent TME for local regrowths. In addition, higher rates of systemic recurrence in those patients who had local regrowth. But again, I think the biology here is a bit different than those patients who underwent near path CR. You can see that the T stage is also a little bit different in the groups, even on multivariate analysis. And then you can see that the local regrowth rates, you can see that the distant metastasis rates are certainly a bit higher. You can see that their main results here showed that there was poor or distant metastasis-free survival in the local regrowth patients versus those who underwent TME. And you can also see that this splays out in terms of the TME groups versus the local regrowth groups. And you can do this, whether you do this by stage or by nodal status, you can see differences in the patients. And I think this is a biologic difference. I'm not necessarily convinced that this is an issue as it relates to patients managed by watch and wait versus those who are taken to surgery up front. So clearly no perfect comparator for this group. I think Laura brought this up in her talk very nicely. And just remember that this is not trial data. These are two studies that are patients taken from two different studies in a very heterogeneous manner. And certainly there's some time bias here that was brought up. So one point that I'll bring up, that they brought up the idea that future studies should consider the subsequent risk of distant metastasis and local regrowth in the design of trials. And I think that's a really important point. And when we designed Janus, which is ongoing, we've carefully considered the risk of local regrowth in the design of Janus. And we use data both from the International Watch and Wait database as well as the recently completed OPRA trial in designing the statistical methodology for Janus so that we can consider local regrowth and made stopping rules in both arms to make sure we weren't seeing any worrisome signals. So people are thinking about this very carefully. So the other trial that was presented was the laparoscopic assisted versus open surgery in low rectal cancer. This is presented by the Chinese group from Fujian, and this is a very important trial because it's there's always this question about open versus MIS surgery, and they looked at differences in disease-free survival, overall survival, because this is always an open question in many studies, including a subgroup analysis in the Color2 trial have always asked, well, is it safe to do this with low rectal cancers? And so they went ahead and asked this in this what's called a laser trial to look at whether or not laparoscopic assisted surgery is non-inferior as it relates to 3-year disease-free survival. So this is a multi-center, 22-center study. Patients were randomized 2-to-1 laparoscopic or open surgery, and you can see this was early stage patients went straight to surgery, and then more locally advanced patients underwent chemoradiation and then surgery, randomized 2-to-1. So primary outcome, 3-year disease-free survival, overall survival, local regional recurrence, and you can see the results. 1,000 patients were randomized, very nicely done. 712 laparoscopic, 358 to open surgery, and 685 and 354 in the intention to treat. No real differences in terms of baseline demographics for the patients. And the only difference is here, there was a bit more sphincter preservation in the laparoscopic arm, and then the length of stay, as you might expect, is lower in the MIS group. No significant differences in terms of the clinical pathologic or morbidity scores in these patients, and they did in fact demonstrate non-inferiority in using the intention to treat assessment, and this was for both disease-free and overall survival. And across stages, you do see a little bit of a trend toward improvement for the laparoscopic group, not for stage 1, but you do see something as a signal as it relates to stage 2 and 3. So they did conclude that that MIS is preferred and non-inferior. If you are very strict, it's non-inferior for the 3-year disease-free outcome, and these data do support the use of MIS for low rectal cancer. So I'll very quickly talk about a few other studies I think you should know about. So one is the Ensemble trial, and I think this is an important trial. This was pre-data for their currently ongoing Ensemble 2 trial that's in Japan, looking at short course TNT, and it's asking a question very similar to what we're asking in Janus, triplet versus doublet consolidative chemotherapy after short course radiation. And here they saw a pass CR of 30%. Some of these patients did go into non-operative management, but this was the phase 2 that led to the phase 3 trial that's ongoing. And I think this is important to note because there are many trials now that are ongoing looking at clinical complete response and organ preservation across the world. The Janus trial here in the US that I'm leading, the CHOW trial led by Rodrigo Perez in South America, asking a consolidation and FOLFOX question, and the Japanese trial that I just mentioned, which is now in the phase 3 status. And then the German trial, which has completely accrued and should report out in 2026, which is looking at short course versus long course, so OPRA versus RAPIDO. And I think this is really important. And this is an ongoing collaboration, and we'll have close to 1,800 patients with CCR as an endpoint, which will be a really important way to look and evaluate also the question about local regrowth. I think will be very cleanly answered in these prospective trials. And this is an ongoing collaboration with all of us. And we've just recently included the Brazilian group in this, now a 4-group consortium, which will answer a lot of these really important questions in a very clean manner. So this was one abstract that I thought was really important. It's another supportive abstract to suggest that TNT was associated with higher pathologic complete response rates, and also higher completion of chemotherapy, and all treatment regimens were completed, radiation and chemotherapy, in rural settings, which I thought was a really important abstract and a point when we're trying to get our patients all of the treatment that they need to give them the best chance for cure. And this was a secondary analysis from OPRA that suggests that restaging endoscopy seems to outperform MRI across all parameters. This is important as we're trying to figure out the best way to identify clinical complete response in our patients after total neoadjuvant therapy. And you can see that the numbers are not perfect for MRI, but with endoscopy, we can approach 72% when we look at a clinical complete response with a true complete response versus MRI. And I think that there's ways that we can get this into a better and a higher rate, but I'll allude to that in a second. So clearly there's a signal for those patients who have a local regrowth and may have a higher risk of distant metastasis, but whether that's answered with non-trial data in the best way, I think, is arguable. I would propose that we stick with prospective data to answer that question. And I think in OPRA, we've shown that. I think certainly there's some concern in those patients, but I think that's a different biology that we need to think about. Certainly, MIS or minimally invasive surgery for rectal cancer is the preferred approach strongly in 2024. I think it's hard to take a really good open surgeon and make him an MIS surgeon, but I think if I was a patient in 2024, I would very much prefer to have a MIS approach from surgery. I think the short course, long course argument is still open in terms of the best way to get patients to a clinical complete response, but the German trial and an ensemble trial, I think, will definitively answer that for us. And there's certainly multiple trial options available for patients who are seeking a watch and wait approach across the US and across the globe currently. I think we have more data now, and there were other abstracts that I didn't mention that again shows TNT is associated with higher response rates and higher treatment completion rates. I think this was a really important paper that was brought out from rural settings, which is a really important data set to share. And then, as I mentioned, restaging endoscopy outperforms MRI. This is supportive of previous data from our group, the group in the Netherlands, and also from the Brazilian group. I think this is a place where AI is really going to help us. And I'll be happy to discuss that when we have questions. So I'll stop there and happy to take questions.
Yeah, thank you so much. That was very interesting. So I will start with some of the questions that I'm seeing in Rectalberg these days, and this is for Dr. Smith. So there has been some posts recently from people who had a TNT approach and they had surgery and they did not have like a PCR. So the question has been, what do they do then? There have been some concerns whether, should they do some adjuvant chemo now since the tumor is not, having a complete response? So my question to you is, based on your, OPRA trial, what can you say about how like a PCR rates correspond to like distant metastasis or overall survival? Like, what is it that patients need to keep in mind?
Yeah, so it's a great question. So the PCR rates in OPRA were about 8% and 9%. So that suggests that we're still not very good at identifying clinical complete response, right? Because that means we missed 8 or 9% of patients who had a clinical complete response, and we took the surgery because we thought that they still had tumor, right? And in fact, they had a pathologic complete response. And there are a lot of data to suggest that if you do have a pathologic complete response, that the disease-free survival and potentially overall survival are higher in those patients. Now, incomplete responders, and this is data from the paper that I alluded to, where we do see differences in disease-free survival outcomes as you look by response. And this is across all, if you look at rectal cancer trials, more modern rectal cancer trials, the German rectal cancer trial, for example, our data, if you look at clinical complete responders versus near complete responders versus incomplete responders, there are differences in disease-free survival. But that's even if you go back to the more classic way that patients were treated, for example, in the German trial where they used chemoradiation, TME, radical surgery, and then adjuvant therapy. And then they graded response of the tumor by pathologic response. So they had a similar complete response, near complete response, or an incomplete response. They still had a very similar outcome, disease-free survival by disease-free survival. And those patients still got adjuvant treatment, right? So when you look at it in the context of TNT, you see the same, right? So whether or not we give patients more treatment on top of that after a TNT approach, I don't think we know that answer, right? Would we affect the biology by giving more treatment? I don't think that we would. I think we would give more toxicity. I think we would potentially harm more patients when the biology is already, in my view, predetermined. So I think we've given them the maximal chance for response by doing TNT. Now, can we give better treatment up front? Should we fine tune the neoadjuvant treatment to give you a better chance of response? Yes. Are we doing that yet? I'm not sure. That's why we're asking the question. And that's where I would refer back to the French data is very interesting to us. And that's why we designed Janus in the way we did, because they've shown that overall survival, which is one of the first trials to show this in a long time, that overall survival has changed, that we've actually started to move the needle to improve oncologic outcomes like disease-free survival or overall survival using a chemo escalation approach.
Okay.
Can I jump
Okay.
in?
Thank you very much.
I just want to add a point. So I feel like this is an area where we really need to individualize radiation treatments to optimize the local response, right? Like, we have these trials, these great large trials where everyone's essentially getting the same radiation, whether it's short course ×5 or long course 54 gray and 28 fractions. But we know that with locally advanced rectal cancer, they're so heterogeneous in terms of size, in terms of biology. Like a small T3N1 doesn't need the same radiation dose to achieve a complete response as like a big T4 distal tumor. So, I had patients who want to be treated with non-op intent, and towards the end of the treatment, they don't have a complete response. They have still residual tumor, maybe not quite a near complete. And a lot of times I ask, can I get more radiation? Can I do something more? And right now we don't have the data for that. But I feel like that's an area that we can really improve on. There are studies on brachytherapy for certain scenarios. We're looking at adaptive radiation. I feel like there's a lot more we can do to optimize radiation for these patients.
Or radius sensitizers too, don't you think, Nina? That'd be a ripe area for radius sensitizers, I think.
Great.
Yeah.
Okay. So for the patients in Rectalberg, like I was kind of wondering if we think that extra adjuvant therapy is not an option, or that there is nothing to show that there is benefit, then is it, can we suggest that those patients who don't have a complete pathological response, they have, a more intensified surveillance? Would that be helpful? Do we do anything like that? What do you think?
That's a great question. And we know from both colon cancer and rectal cancer data that enhanced surveillance is not associated with better long-term outcomes, right? So if we check CEA every 3 months, if we, do more scans and things like that, it's not associated with improved outcomes. And there's pretty high quality data. Rebecca Snyder, who's my cohort on the GI Alliance committee, has done a really nice study that I'm happy to send to you, Manju, and you can distribute it. But I don't think we're to that point that enhanced surveillance is really the answer. I think surveillance is important, and we do know that, and there's our data support that we need patients. We can't just not see them. We know that physical exam is important, and endoscopic surveillance is important. But do we increase surveillance to detect either distant or local disease? I don't think that's the answer at this point. Do we need better non-invasive tests? Yes. Is Natera the answer? I don't think so. I don't think that test is good enough to detect when disease comes back. I think we need better non-invasive tests to tell us that something is on its way back or it hasn't been eradicated, right? So I think our technology is not there to detect early recurrence.
Yeah, just on the ctDNA point, we're following patients with ctDNA who are on a watch and wait trial, and they're clearing their ctDNA very, very early, but clearly still have residual cancer there that you can see on scope and MRI. So I totally agree with Josh that it's not sensitive enough for early stage rectal cancers.
Okay.
Manju,
Thank you so much.
Your questions are really on point, though. I think it's nice to recognize that these patients that have pathologic residual disease that are at higher risk and prognostically in a poorer shape than many patients that have a complete response. And I'd also echo the very thoughtful responses of Josh, that at this point it seems to be purely prognostic, and at least I'm not in a place to suggest that may be predictive of that some intervention can, at least at this point, offer better outcomes for patients. I also think that it may be a prime opportunity for novel biomarker-based research to better identify or enrich a cohort that may drive benefit from another intervention strategy. But at the same time, I worry about the quality of life cost that if we universally apply added intervention for a group that has pathologic residual disease without some added biomarker to guide it, I think we may end up hurting more patients, at least at this point. But I think it's a perfect opportunity for a clinical trial.
May I comment on that? Because as a caregiver and wife a mother of a 2-year-old, ctDNA, and having understood from the get-go that the prognostic kind of ability of ctDNA, especially in the stage 4 setting or metastatic setting, is very limited, there is something that is not being considered by clinicians, which is the ability that ctDNA gives you to plan, okay, in advance, and to maybe book earlier scans, or to start to fight with your insurance company earlier so you can access treatment. That is something that we need to incorporate in the equation of quality of life and what it means for patients. I've talked and I engaged with many patients who were part of the first bespoke ctDNA trial in Argentina, and the sense of the clinicians about anxiety being caused by ctDNA is just the opposite for many patients who clearly understand what are the limitations of the tests. So it is very expensive though, okay? Yeah, as a planning tool, it's very expensive for patients. So, but I think we need to incorporate that into the patient dimension of the ctDNA testing, because planning, especially for early onset colorectal cancer patients, is very, very important.
Yeah. Thank you, Natalia, for bringing it up. So going back to the, sorry, I'm stuck with that incomplete path response. Is it like, so statistics wise, from previous results, what is the rate? Like, so for example, if you have 100 patients without a PCR, what is the rate of, or the chances of distant recurrence for those patients? Is it like, from what I understand, it increases the chances of distant recurrence, but doesn't mean that everyone who doesn't have a path CR will go on to progress, right?
That's right, because we know from the data from our group and also from MD Anderson, and also if you look at the German trial, even if you have a path CR, there's still a chance you can develop distant metastatic disease. So it's 6 to 8% of patients with a complete response can still develop distant metastatic disease, right? So it doesn't mean that you're scot-free if you have a pathologic complete response, right? So there's still a chance you can develop progression of disease even with a complete response. So there's still a chance, a small chance. I mean, it's not the same if you have an incomplete response, but there's still a chance.
Yeah, I share that perspective. Manju, there is precedent for the question that you're asking. The ADORE study, which looked at patients that got long course chemoradiation, and if they had pathologic residual disease, they're randomized to 5-FU leucovorin versus FOLFOX. And there was a DFS benefit with FOLFOX, but I'm not aware of any study in the TNT era that folks got pre-op chemo and chemoradiation, and if they have pathologic residual disease, randomizing to further intervention at that point in time.
Okay. I think where
the only study that gave additional adjuvant therapy in a TNT-like approach is the PRODIGE 23 study, where, right? And the reason that they did that is because they couldn't get the medical oncologists in France to give up the idea that patients needed additional adjuvant therapy. So it's a little bit, it's not true TNT. Like not all the therapy was given pre-surgery. So it's, you have to take that with a little bit of a grain of salt. But everybody, both in the treatment arms, they had a consideration based on the treating physician, the ability to get adjuvant therapy. So, but I agree that there's not a clean study out there where patients are, okay, you have an incomplete response, and now we're randomizing people to get treatment versus not treatment. I would argue that that's very similar, Manju, to randomizing patients who have a clinical complete response to TME versus not, because I'm not sure that either clinicians or patients would have equipoise for that study. Because if I randomize you and said, sorry, we're going to observe you versus getting treatment, I'm not sure patients would sign up for that study.
Yes, I completely agree. I think this discussion is great for people who are, interested. And I think the PRODIGE model is what is causing a little bit of anxiety, because in that, some of the adjuvant chemo was given later, and what you just answered is like the perfect response for that. So thank you so much. So we look at, there are a couple of questions. There is one long question about screening. Are there differences in terms of follow-up screening for polyposis serrata versus adenomatous polyps in young patients? And then,
In terms of follow-up screen for polyps, gosh, I will have to get back to you on the details for follow-up for the different colonoscopy findings. I don't want to say the wrong thing. I'll get back to you though.
Okay. And then could you comment on the performance of occult blood tests versus colonoscopy in right-sided CRC? Could you talk about the role of digital rectal exam in rectal watch and wait compared to sigmoidoscopy? Maybe the second part of the question, maybe for Dr. Smith.
Yeah. So we know that digital rectal exam is important, but it's not the only part of the equation, right? Because it can be quite subjective, right? Because I can feel a scar and then somebody else can feel it and say, oh, I think that's tumor. And there's a study from our group in 2005 that was published in JCO where patients were taken to the operating room and found to have path CR where the digital rectal exam was thought to be abnormal. Okay. So in many cases, the digital rectal exam can be wrong. So it's a part of the exam, but it's not all of it. So endoscopy, MRI, that's why it's a regression schema with 3 parts to the exam. And it's also why we don't exclude patients from a watch and wait approach that have mid-rectal tumors that some clinicians can't feel, because they may have a beautiful clinical complete response by endoscopy, and some people, their fingers just aren't long enough to reach the tumor that's at 8 centimeters. So we don't exclude patients, for example, in Janus because they have a mid-rectal tumor, because they might have a beautiful clinical complete response and be a good candidate for organ preservation.
Okay.
Yeah, and your question about the occult blood versus colonoscopy. So my understanding is that their sensitivity is similar. And colonoscopy obviously gets to the right-sided colon. But from the studies, the main benefit of the colonoscopy is detecting the pre-malignant polyps.
Okay. Dr. Jethwa, did you have a comment about any of this?
Yeah, I actually do. I'm curious, polling Nina and Josh about a question that I often hear from other institutions and even folks in my own, and it's in patients that have some questionable findings, or perhaps you have concern of local regrowth endoscopically. What do you think the role of biopsy is? And even more importantly, let's say you biopsy it and it's negative. How do you approach it? I certainly have my own opinions, but I'm curious yours.
So I definitely agree with a biopsy if there's concern. I think if you're going to do a biopsy, then you have to kind of trust if it's negative, right? Otherwise, if you're not going to act, if you're going to say it's negative, I'm still going to go forward, then, it's like, why'd you do the biopsy? But I would probably argue, so biopsy, and then if there are any other imaging modalities that could be helpful in that situation, like obviously an MRI, but sometimes we've also gotten PET scans as well. Maybe ctDNA, though, as I just mentioned, it's probably not sensitive for like an early regrowth. But probably, I would recommend biopsy and then urgent consideration of other tests. What about you, Josh?
So there's there's data from the Brazilian group, and then also Julio has a really nice study from when he was at UCSF that showed that the negative predictive value of a biopsy is quite low. And the reason is because when we use a biopsy forceps, that the biopsy even the mega biopsy forceps is 5, it gets close to 4 millimeters, but the standard biopsy forceps 2.9 millimeters, right? So you can imagine that if the tumor is regrowing and it's submucosal, so if I take a biopsy and it's negative, but the tumor is coming back deep in the wall of the rectum, I'm not going to get to that tumor, right? So I could say, okay, my biopsy is negative and have a false hope that that's truly a negative biopsy. So, sometimes a patient needs a biopsy to prove to them that they need a TME in the context of local regrowth. And in that case, sometimes you have to go to the operating room to take a deeper biopsy in order to do that. But I think biopsies can become quite problematic. And we did not recommend biopsies in OPRA, and we did not recommend biopsies in Janus for that very reason, because the negative predictive value is very, very low and can become very troublesome. And you can imagine when a tumor starts to come back, You might see one area that you take multiple biopsies and you can still miss the tumor coming back. The approach for local regrowth and the safest thing that we know to date is a TME. And I think that that's the safest way to manage those patients, right?
But what if your scope and MRI findings are like inconclusive, right? I totally agree. If you see on the scope, it's a clear local regrowth. Yeah, you don't need the biopsy. But what if you're just not sure based on your scope and your MRI?
Yeah, I think the safest way to manage that is you can give more time. You can, there's no reason to rush, right? You can wait another 4 weeks. You can wait another 8 weeks. Especially when you're starting to see a local regrowth and you don't have any evidence of distant metastatic disease. You have time. There's no rush. You don't need to take that person to the operating room that week or even in a month. You have time, right? So there's plenty of time to manage this carefully and do it in a multidisciplinary fashion. These are all patients that we discuss at Tumor Board.
Okay.
Yeah, I'm glad I asked the question, and you guys kind of set it up perfectly for what I was hoping, is hearing the differing perspective on the same question. And just like Josh,
because we almost always try to biopsy the recurrences, so it's interesting to hear your perspective of maybe not biopsying them and either waiting or just taking them straight to surgery.
Some patients have to have a biopsy proof of it, and but sometimes you just can't because the tumor is submucosal and you can't do it without. And the other problem is occasionally the biopsy proof has to come through local excision, and that local excision will render the TME inadequate and oncologically inappropriate, and it could hinder your margin. So you have to be very careful there.
Yeah, no, I just think from our patients and maybe even the clinician standpoint, this is a patient who's achieved a complete response and avoided surgery. So we just want to be absolutely sure that they have cancer there before committing to this procedure that they have fought so hard to avoid, but that's very helpful.
Yeah. I think that's one question. Does APR surgery improve recurrence rates for a non-PCR patient? I think it's maybe compared to low anterior resection is maybe what they're asking.
Josh.
Oh,
let me see if I can understand that question. So
I think, Josh, they're suggesting that if you have an LER and there's residual disease, just proceeding with a completion APR risk of recurrence.
Yeah, I mean, bad biology is bad biology, right? I mean, I think in the era of TNT, I think what we're going to see is an enrichment of some bad biology, right? That's a great question. We have some data to address whether because we're taking all the good responders out of the equation now, and we're being left with patients who have, what we think of as incomplete response. Does it matter if you have a very low coloanal versus an APR? Are the outcomes going to be different there? I think this is a great question. I think in the era of TNT, we might see some differences here.
I share that perspective too.
Yeah.
I mean, just because if you have a disease burden that's involving or very close to the sphincter complex initially, and you have significant regression of the tumor with total neoadjuvant therapy, and you proceed with a sphincter preserving operation, I do think that there's a potential risk of occult residual disease adjacent to your anastomosis. But if you have a patient that has a disease burden that you think at initial diagnosis can be sufficiently managed with appropriate margin with an LAR surgery, in those cases, I do not think proceeding with a completion APR would offer any significant benefit to that type of patient.
Other than rendering them with a permanent stoma with potentially no oncologic benefit.
Yeah, I think maybe Jill, please, tell us in chat if your question has been answered.
Jill, we have there's a paper coming from us. I think will help answer that question for you. So keep your eye peeled for that.
Okay. And I think in between, there's one more question about ctDNA. So where does ctDNA come into play with rectal cancer? I think you guys have answered it, but then we'll see. I had negative ctDNA prior to local excision, Signatera, and so far I've continued to have negative ctDNA a year afterwards. What prognostic value does that pre-surgical and pre-treatment ctDNA add?
Yeah. I mean, I think Nina said it well. I mean, the technology is probably not good enough to detect these early stage, maybe even up to some stage, what we would consider stage 3, let's say a T3B tumor. They might not even be able to detect that tumor well before treatment. So, a very early, T1 tumor that's a candidate for local excision, maybe the technology is not good enough to detect that tumor and that it's gone. So I'm just not convinced we have the right technology at present.
Yeah.
But,
Okay.
I'm a scientist and a bit of a skeptic by nature. So once I see better data and I see it in a prospective, really well-controlled fashion, then maybe it'll reduce some of my skepticism.
Yeah. Dr. Jethwa?
I'm just going to add to what Josh shared that I'm also kind of of a similar perspective, maybe a purist of data by heart, and that I would also like to see ctDNA used as an integrated biomarker on a prospective study to help really direct that question.
Okay. I think that Dr. T had some results with her dynamic rectal, but they were basically saying that ctDNA was a good predictor of distant metastasis, but could not be used for local recurrence at all. Like it was not useful.
Correct.
So there's another question. For those with pelvic recurrence who have undergone chemo, surgery and never received radiation therapy, is there any evidence of improving outcomes using RT versus chemo RT after first line?
Sounds like a good question for Dr. Sanford.
Yeah. And Krish, feel free to chime in. But yeah, so the short answer is we do see these, particularly sort of mid-upper rectal cancers that initially were treated without pre-op radiation. And these are scenarios where typically we would probably advocate for pre-op radiation, again, in the recurrent setting. We have to look at where the tumor is. Is there a concern for a positive margin when they go to surgery? But my experience with these local recurrences is they tend to be less well circumscribed. They tend to be, sort of more infiltrative. A lot of times they're near the pelvic sidewall. And then also there's a question of, if there's one local recurrence, is there other micrometastatic disease in field that could be addressed with pre-op radiation? So obviously it's a case-by-case basis, but these are scenarios where we would often recommend pre-op radiation.
Okay. Dr. Jethwa, do you have anything to add?
I think Nina said it really beautifully. I agree with everything she shared. We have a pretty robust local region recurrent practice here, and we often also incorporate intraoperative radiation therapy for high-risk margins and those that do have the compromised scenarios like Nina mentioned.
Okay. What else? Yeah, this is almost a basic question, but one that's common asked in Rectalberg, which is about short course radiation and long course radiation, right? And I think Dr. Jethwa's slides explained it really well, that if you are interested in pursuing watch and wait, then maybe long course is a good option to go. But, do you have any other, comments about, patients getting short course versus long course, and how, for example, for surgery, is that an issue? Do you see more fibrosis, or are there any other concerns that you find? Say, for example, a patient doesn't want non-operative management and they would like to choose short course. What are some of the things to keep in mind?
Yeah, I mean, I think it's a great question. I'll defer to the surgical question directly to Josh. But I mean, I think, currently we can be pretty comfortable that both long course and short course radiation therapy are appropriate data supported regimens as a preoperative treatment technique for patients with advanced rectal cancers. RAPIDO used a short course backbone with TNT. Purdue 23 and others have used long course. We have many studies, a handful that have looked at long course versus short course in patients with standard risk rectal cancer. And by and far, the data is essentially suggestive that both are reasonable treatment approaches. I know in the US, there's been a lot of debate of long course versus short course. It's gone on for decades. It will never end. That debate will always be there. I think with the RAPIDO study, there's at least some suggestion that long course may be more favorable or preferable in a group that is enriched with high-risk rectal cancer. It was a very high-risk study, many of which had pelvic recurrence risk factors. So at least in my practice, I used long course for those with high-risk pelvic risk factors, compromised MRF, lateral pelvic lymph nodes, T4B tumors specifically. But I think you could still, use data to support short course even in that group. As to the watch and wait or organ preserving approach, the strongest data that we have to date has used long course chemoradiation. Although I can tell you there are data looking at short course radiation therapy even in that space. There's the normal R study out of WashU. There's the NOM-ERA study out of WashU. And there's multiple others, the TREC study that used short course followed by transanal excision, etc. There's lots of studies in that space also. So at least for standard clinical practice, I use long course for organ preservation. But if I had a patient that told me, hey, I can't come for 5 weeks or 6 weeks, I would still be comfortable using short course as an organ preserving approach if it fit what that patient needed that fit best with their life.
Okay, thank you very much. Dr. Smith, do you have any comments about surgery?
Subjectively, we do see a bit more toxicity with short course, but I do agree that some patients just can't do long course. For especially some younger patients, it's very difficult to set aside 6 weeks of time. So we do see clinical complete responses. I think from my view, I will await the German trial to see what is the best way to get to organ preservation, comparing the two groups. I think that'll be a very well done trial. And then I think the Japanese trial will also help us to decide if it makes sense to escalate chemo after short course. In that regard, I think those two will be very illustrative of what's helpful. From a, if a patient needs to use short course versus long course based on individual preference, I think we can have some equipoise in that regard, because we feel like we can still treat them oncologically in a safe and efficacious manner. There are some toxicities, both long and short term, that we have to deal with, but at the end of the day, I think we can get the patients through the treatment.
Okay, thank you so much. I think that this will be the last question. Thank you so much for your time. And then this question is about proton beam therapy versus SBRT. So maybe Dr. Jethwa and Dr. Sanford, you can take it.
Sure. So the question, is there any advantage using proton beam therapy versus SBRT for organ preservation or to prevent long-term morbidity? So just a little bit of background. So the benefit of proton beams is that they have a very sharp dose fall off. So if you are treating a structure that is like right next to, the optic nerves or the spinal cord, and you want 0 dose, like next to your target, then that may be beneficial. There are potential other scenarios as well. I think in rectal cancer, because the fields we're treating are a little bit more generous, because we're encompassing both the gross tumor and where there could be microscopic disease, I'm not convinced that there is a clinical benefit to protons. I think if you look at a plan on paper, it's always going to look prettier, but whether that translates to a clinical benefit, that hasn't been shown. And then kind of similar, so what is SBRT? Another name for it is SABR. The premise behind SBRT is very high doses of radiation in very few fractions to a small target, usually just to the tumor alone. And generally, at this point for rectal cancer, we're not using SBRT because, again, we treat a more larger sort of volume to encompass where there could be microscopic disease. That being said, I think, when I talked a little bit earlier about individualizing radiation and potentially dose escalating areas of our target, I think if in the future we are escalating our dose to the gross tumor with sort of a short course technique, we actually have a trial doing that here. We actually do sort of an SBRT setup where we can be more focused to the area of the tumor. So a little bit of a nuanced answer, yes and no.
Okay.
Yeah, I shared Nina's thoughts about proton therapy, although I would like to add one scenario. So in my practice, I treat almost all with photons or x-rays, but there's one specific cohort of patients that I think could derive benefit from protons, and it's the young premenopausal women that are not interested in ovarian transposition surgery. So we know that with photons, the risk of infertility is 100%, and the risk of premature ovarian endocrine failure also approaches 100%. The best way to reduce that risk is to physically move the ovaries out of the pelvis with a transposition surgery, and we can spare endocrine function in 75% or more patients that have the ovaries physically moved. But proton therapy, by having that dose distribution that Nina suggested, in some patients who are not interested in moving the ovaries surgically, we can actually design a field arrangement such that we don't have dose deposition in the ovaries, and we can still sufficiently treat their pelvis. And at least on paper, dosimetrically, the ovary sparing that we can achieve in some is suggestive that we could reduce the risk of ovarian endocrine failure by the use of protons. So it's that specific group that I tend to advocate for the use of proton therapy. Almost all others, I favor X-rays or photons.
Okay, thank you. This is very, very important and interesting to know. I think this will be the very last question. Thank you so much for your time. So this is about risk for secondary cancers after pelvic or pelvic radiation exposure. What do you think? What's the risk?
The risk is not particularly high, but I'm also not sure it's fully accurately reported. So I tend to estimate to patients that the risk is about 0.2 to 0.3% per year after radiation therapy. It's a cumulative risk. So you can imagine that by 10 years, maybe you're at a 3% or higher risk of radiation-associated secondary malignancy. By historical classical definition, they have to occur within the radiation therapy field, and they have to occur at least 5 years after the treatment. It's very rare to have a radiation-associated malignancy sooner than that. Not impossible, but rare. But it's not a particularly common risk.
Yeah,
Okay.
for solid cancers, yeah, about 5-10 years. For hematologic malignancies, it can be a little bit shorter. And then, yeah, the question of age. So younger patients are more susceptible to developing a secondary malignancy. So it may be a little bit higher, though that really plateaus by around age 30. So when we're saying young patients, we really mean very young patients. But yeah, I agree with what Chris said.
Okay, thank you so much. This was very informative and we covered a lot of things. So thank you very much for your time and thanks to everyone for attending.
Thanks, Manju. Take
So
care.
much for having us.
Good to see everybody. Yep. Take care.
Bye.
Bye.